Okay, so we did somatic symptom disorders. These disorders are characterized by physical symptoms that defy medical investigations. They cause significant distress to the individuals and can cause serious functional impairments that will cause the individuals to become, that may cause the individuals to become socially or occupationally disabled. They are relatively common, with up to 30% of primary care patients presenting with medically unexplained symptoms. And that's not saying that up to 30% of primary care patients have these disorders, but they are displaying some sort of symptoms. In the DSM-5, the focus has shifted from somatic symptoms themselves to the excessive thoughts, feelings, and behaviors that arise in response to those symptoms. And so somatization disorder, hypochondriasis, pain disorder, and undifferentiated somatoform disorder in the DSM-4 have now been consolidated into the somatic symptom disorder in the DSM-5. So the somatic symptom disorders include somatic symptom disorder, illness anxiety disorder, conversion disorder, psychological factors affecting other medical conditions, and factitious disorder. And then there's two categories involved in that as well that don't go necessarily with those disorders. So additionally, individuals can experience other specified somatic symptom and related disorder, or unspecified somatic symptom and related disorder.
So the first disorder is somatic symptom disorder. This is characterized by the presence of one or more somatic symptoms that are distressing and or result in significant disruption of daily life. The concerns for this disorder have to have been present for at least 6 months, but not necessarily with one symptom continuously for those 6 months. Symptom migration, in which an individual previously was preoccupied with a particular symptom, will then focus on a new symptom, is not uncommon. As Savannah mentioned, this diagnosis replaced 4 disorders in the previous version of the DSM. With this disorder, quality of life is often significantly impaired, particularly when the disorder leads to a high level of medical care utilization. The diagnostic criteria for the somatic symptom disorder include one or more somatic symptoms that are distressing or result in significant disruption of daily life, excessive thoughts, feelings, or behaviors related to the somatic symptoms or the associated health concerns as manifested by at least one of the following: disproportionate and persistent thoughts about the seriousness of one's symptoms, persistently high level of anxiety about health or symptoms, or excessive time or energy devoted to these symptoms or health concerns. Although any one somatic symptom may not be continuously present, the state of being somatic is persistent and typically more than 6 months. So the specifiers are with predominant pain, in which this is for when individuals whose somatic symptoms predominantly are involving some sort of pain. And then persistent is the persistent course, is being characterized by severe symptoms, marked impairment, and a long duration, which is typically more than 6 months. There are 3 types of severity. So the mild severity is when there's only one of the symptoms that was specified in criteria B. Moderate is when 2 or more of the symptoms, and then severe is 2 or more of the symptoms, plus there are multiple somatic complaints or one very severe somatic symptom. The prevalence, so we typically see between 5 to 7% in the general population, though it is typically higher in primary care. Women tend to report more of these somatic symptoms, and you typically see an onset in the 20s, though you can also see another resurgence in elderly patients as well. The risk factors include low levels of education and low levels of income.
Okay, so the next disorder we're going to talk about today is illness anxiety disorder. It's a new diagnosis in the DSM-5. This disorder is characterized by patients that are preoccupied with the possibility of having or acquiring a serious illness. They may amplify normal physiological sensations and misinterpret them as signs of disease. And the distress that they experience comes mainly from his or her anxiety regarding the meaning, significance, or cause of the symptoms rather than the actual symptoms themselves. So some individuals would have fallen under the diagnosis of hypochondriasis under the DSM-4. And if a diagnosable medical condition is present, the individual's anxiety and preoccupation is disproportionate to the severity of the medical condition itself. So these individuals are easily alarmed by ill health and tend not to be reassured by negative medical tests. They experience incessant worry that may lead to family members becoming frustrated and causing strain within their relationships. They have a hypervigilance regarding health and engage in significant checking behaviors similar to those who have obsessive compulsive disorders. And while physicians may find these patients difficult, on the other hand, these patients feel ignored or rejected by those same physicians. So the diagnostic criteria for this includes a preoccupation with having or acquiring a serious illness, somatic symptoms that are not present or, if present, are mild in intensity, and if another medical condition is present or there's a high risk for developing a medical condition, the preoccupation is clearly excessive or disproportionate. There's a high level of anxiety about the health, and the individual is easily alarmed by the status of personal health. The individual performs excessive health-related behaviors or exhibits maladaptive avoidance. Illness preoccupation has been present for at least 6 months, but the specific illness that is feared may change over that period of time. And the illness-related preoccupation is not better explained by another mental disorder, i.e., somatic symptom disorder, generalized anxiety disorder, etc. So there are 2 specifiers with illness anxiety disorder: the care-seeking type, which is seeking out medical care, including physician visits or undergoing tests and procedures that is frequently used, and the care avoidant type, which is the opposite, in which medical care is rarely used. For prevalence, it's thought to be between 1 and 10% of the general population based on evidence from the previous diagnosis of hypochondriasis, with the prevalence being similar in women and men. There's an unclear development of course, although it is generally thought to be chronic or relapsing. The age of onset tends to be in early to middle adulthood, and it's very rare in children. Illness anxiety disorder may be brought on by a major life stress or a serious yet benign threat to an individual's health. A history of childhood abuse or of serious childhood illness may predispose individuals to the development of this disorder in childhood. And approximately 2/3 of individuals are likely to have at least one other major mental disorder and are at higher risk for somatic symptom disorder and personality disorders.
So the next disorder that we're going to talk about in this diagnostic class is conversion disorder, which is sometimes known as functional neurological symptoms disorder. And this is defined by the presence of one or more symptoms of altered voluntary motor function or sensory function that suggests a neurological or medical condition. The cause is not well understood. Most individuals who receive this diagnosis do have a history of a mood disorder, a somatic symptoms disorder, or a psychotic disorder. And the key thing here is that these symptoms are not consistent with any known neurological or medical conditions, but they are real symptoms that the individual is experiencing, and they're not fabricating these symptoms. So the prevalence, conversion symptoms are fairly common. The exact prevalence of them is not known, but it's estimated that there's about 2 to 5 per 100,000 new cases a year. Conversion symptoms are more common in patients from rural areas with lower levels of education or income, and are 2 to 3 times more common in women. So the symptoms often conform with the patient's concept of a disease rather than recognize psychological patterns that go along with that disease. Patients will sometimes mimic symptoms based on their prior experience with an illness or the experience of a close family member who's had that illness, like a parent or a grandparent. Typical symptoms are usually paralysis, abnormal movement, so like muscle twitch, inability to speak, blindness, deafness, and pseudoseizures. And pseudoseizures mimic epileptic seizures, but they are not, but you do not see the same brain activity with the pseudoseizures that you would in an epileptic seizure, so they are a little different. Conversion disorder is associated with dissociative symptoms like depression, derealization, and dissociative amnesia. So particularly on the onset of symptoms or if during an attack like a pseudo seizure or paralysis, it's often found that patients will not remember those attacks. Clinicians should be aware that these symptoms are possibly medically based because patients that are diagnosed with conversion disorder do sometimes go on to be diagnosed with an actual neurological illness or medical condition that in retrospect explains the symptoms that they were experiencing. So the onset does tend to be in late childhood or early adulthood, but it may occur through any point throughout life. Usually the later onset that it occurs, the more likely that it's tied to an actual neurological or medical condition. The onset may be associated with stress or trauma, either psychological or physical. Onset in middle or late age does suggest a medical condition, like I said. So the risk factors include maladaptive personality traits that are commonly associated with, these are commonly associated with conversion disorder. There may be a history of childhood abuse or neglect. Stressful life events do often occur in individuals who develop conversion disorder, but they're not always present. So one thing to note with that is the textbook does say that even if stress or trauma is not present in the person's life, that should not rule out a diagnosis of conversion disorder. And then the prognosis factors, a positive prognosis is associated with a short duration of symptoms and the acceptance of their diagnosis. Negative prognosis is associated with maladaptive personality traits and the presence of comorbid physical disease and if they receive disability benefits. So this is the DSM-5 diagnostic criteria for conversion disorder. So the different categories that they meet are one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptoms and recognized neurological medical conditions. The symptoms of deficit are not explained by another medical or mental disorder, and the symptoms of deficit cause clinically significant distress or impairment in social, occupational, or other important areas of functioning that warrant medical intervention. So this specific symptom type, these are similar to the symptoms that I just stated on the other slide, but weakness and paralysis. So this is how you can specify them when you're diagnosing conversion disorder. So with weakness or paralysis, with abnormal movement, with swallowing symptoms, with speech symptoms, with attacks or seizures, with like sensory loss, with special sensory symptoms, so like visual, olfactory, or hearing disturbances, and then with mixed symptoms. And then you can also specify with an acute episode or persistent. So that is dependent on whether the symptoms have lasted for 6 months or not. And then with psychological stressors, which you would then list those specific stressors, or without psychological stressors. So the treatment for conversion disorder is not well established, but usually the treatment is based around the removal of symptoms as the goal, along with an effort to resolve the stressful situations that may accompany the symptoms. Behavior modification has been shown to be helpful in treating patients with persistent conversion symptoms in an inpatient setting. So really what this looks like is in an inpatient setting, they'll have a patient with conversion disorder and put them on strict bed rest so they don't have access to the other facilities in the inpatient treatment center. And then over time, as their condition starts to improve, they will then get those privileges back. So this cuts down on like the secondary gain that can sometimes come with conversion disorder symptoms in terms of the patient is seeking specific attention-seeking behaviors with conversion disorder. So this has shown to be effective, but only in inpatient treatment. Reassurance and gentle suggestions by the practitioner are appropriate. There's no evidence to suggest that confronting someone with conversion disorder about their symptoms is useful because, as I mentioned earlier, these are legitimate symptoms that these individuals are experiencing. They're usually not fictitious or made up. Hospital staff should remain supportive and show concern while encouraging self-help behaviors. Treatment for this disorder should emphasize rehabilitation rather than medication. And the spontaneous remission rates is very high for conversion disorder symptoms.
All right, psychological factors affecting other medical conditions. It is a medical symptom or condition that is not considered a mental disorder. It was added as a new disorder in the DSM-5. These are factors that negatively impact medical conditions. Comorbidities, as there is not a lot of research out about this, they're not very well known. Although stresses and prior trauma appear to be a precipitating factor, as well as adjusting to a new diagnosis, such as finding out one has asthma or one is dealing with cancer or perhaps a detrimental heart issue. The research data is unclear on how common it is, but with the few studies that do exist, it shows that there may be a slightly higher prevalence than with somatic symptom disorder. It can occur at any age, including with children and the elderly. In order to be diagnosed with this, the individual must also have a medical physical condition. There are no marked risk factors that distinguish between ages or sexes, and very scant research on culturally bound factors or other demographics. Patients might present as treatment failures or with aggravations of medical conditions associated with stress. If this is suspected, differential diagnoses would be adjustment disorders, illness anxiety disorder, a mental disorder due to another mental or medical condition, and somatic symptom disorder. The diagnostic criteria would be that there's a medical symptom or condition other than a mental disorder present. Psychological or behavioral factors adversely affect the medical condition in one of the following ways. It could be that the factors have influenced the course of medical condition as shown by a close temporal association between the psychological factors in development or exacerbation of, or delayed recovery from the medical condition. The factors interfere with the treatment of medical conditions, so poor adherence to a treatment plan. The factors constitute additional well-established health risks for the individual. The factors influence the underlying pathophysiology, precipitating or exacerbating symptoms or necessitating medical attention. The psychological and behavioral factors in criterion B are not better explained by another mental disorder, such as a panic disorder, anxiety disorder, major depressive disorder, or PTSD. Specifiers are in the amount of severity we see in this. So it would be mild, increasing medical risk, so not being consistent with a medication regimen. Moderate, so aggravating the underlying medical condition, such as anxiety, making asthma more difficult. A severity or a severe case would be resulting in medical hospitalization or an emergency room visit. And the most extreme case is a severe life-threatening risk, such as ignoring heart attack symptoms. Treatment is usually cognitive behavioral therapy-based, mindfulness-based, or with a integrated health approach. So a mental health professional would join a treatment team to further monitor and encourage the correction of the detrimental behaviors and work on building a more positive behavior set. So this would be looking at what's gone right in the past, building skills, symptom tracking, and doing everything one can as an integrated mental health or an integrated health team to improve overall health outcomes. These clients should also be screened for other mental or physical health issues that might complicate the existing conditions like substance misuse, PTSD, or organic forms of dementia.
Another disorder in the somatic disorders is fictitious disorder. A fictitious disorder is characterized by intentional production or framing of physical or psychological signs or symptoms. So there's no obvious external incentive for behaviors such as an economic gain. Individuals are thought to be motivated by an unconscious desire to occupy the sick role. Some fictitious disorder patients appear to make hospitalization a way of life and are often referred to as hospital hobos or perinating problem patients. Many have heard the term Munchausen syndrome. This has also been used to describe patients who move from hospital to hospital simulating various illnesses. This name came from the fictitious wandering of the 19th century Baron von Munchausen, known for his tall tales and fanciful exaggerations. The fictitious diagnostic criteria imposed on self says falsification of physical, psychological signs or symptoms, or induction of injury or disease associated with identified deception. The person presents him or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. The behavior is not better explained by any other mental disorder, such as delusional disorder or another psychotic disorder. There is also fictitious disorder imposed on another. The falsification of the physical or the psychological signs or symptoms or induction of injury and disease associated with identified deception. The individual presents another individual, the victim, to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. Now, this behavior is not explained by any other mental disorder, such as delusional order or any other psychotic disorder. Note that the perpetrator, which is the individual presenting, not the victim, receives this diagnosis. Now, specifiers for on self and on imposed on another are the same. So you have single episode or you have recurrent episodes, 2 or more events of falsification of illness. Now, there are clues on how to diagnose this. If they have a lengthy or involved medical history that does not match the patient's apparent health and vigor, the clinical presentation is too closely resembles the textbook descriptions. They're very knowledgeable about medical vocabulary. There's a demand for specific medications or treatment, and they have a history of excessive surgeries. Now, the prevalence is unknown, most likely due to the fact of the deception. But in a hospital setting, it is estimated that 1% of patients have presentations that meet this criteria. Most cases involve the simulation of physical illness. Typical uses of one of 3 strategies is to feign illness. One is just basically falsifying and reporting an illness without having them. The second one is producing false evidence of an illness, for example, using a thermometer and rubbing it to create friction, which increases the temperature on the thermometer. Then there's the third, which is intentionally producing symptoms of illness. In some cases, they use warfarin, which is a blood thinner, to cause bleeding, or they may inject feces into their system or insulin to create a physical illness. Typically associated with the presence of a personality disorder, for example, borderline personality. Most have maladaptive personality traits, but none have a diagnosis of a major mental disorder, such as major depression or schizophrenia, and nearly all of them were women. The course of action, in most cases, you would use a psychiatrist, a social worker, and the attending physician to do a confrontation in a non-threatening way. Another consequence to this is, in the case of inflicting on another person, is a criminal charge, per se, child abuse, or if they're doing it against an elder abuse. And in that case, they would have to face charges for those crimes.
So other specified somatic symptoms and related disorders. So how this category is defined as it applies to cases in which symptoms of a somatic symptom or related disorder are present, but the full criteria for any of the disorders in the diagnostic class are not met. And these are common enough they do have their own diagnosis because they do not meet the full diagnostic criteria for another disorder in the somatic symptoms. class that is more common. So we have brief somatic symptom disorder, so the duration of symptoms is less than 6 months. We have brief illness anxiety disorder, again, duration of symptoms is less than 6 months. Illness anxiety disorder without excessive health related behavior, so that criterion D for illness anxiety disorder is not met. And then pseudocyesis, which is a false belief of being pregnant, and it is associated with an objective. So those are the 4 that fall in the other specified somatic symptoms. And then we have unspecified somatic symptoms and related disorders. So again, it applies to cases in which symptoms that are characteristic of a somatic symptom or related disorder are present, but the full criteria for any of the disorders in the diagnostic category are not met. Symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. And this category should not be used unless there is decidedly unusual situations where there is insufficient information to make a more specific diagnosis. The textbook does say that you want to try and refrain from using this diagnosis as often as possible. It's really just for those outlier circumstances that do not fit into one of the other categories that we just talked about.
Okay, so next we're going to transition into our case study in which we're going to be looking at a mother, Priscilla, played by Savannah, who is presenting her daughter, Monique, who's, oh, sorry, I got that mixed up. The daughter is Priscilla, who's played by Savannah. The mother is Monique, played by Yvette. And the mother is presenting with factitious disorder imposed on another. So now we're going to be seeing Priscilla and Monique presented at the hospital emergency room and are now in a private room. The social worker, played by September, and the nurse, played by Bailey, are coming in to meet with them for the first time.
All right. Let's see. Monique, correct?
Yes, yes.
Hello, I'm September. Very nice to meet you.
It's nice to
I'm
meet you.
sorry. I feel bad that it's under these kind of circumstances, though, since it does sound like you've come in with your daughter, Priscilla, with emergency symptoms of, or to the emergency room with symptoms of leukemia. Is that correct?
Yes, yes. I've been trying now for several months to get someone to listen to me because I really believe, and I know that she has all the symptoms of leukemia.
Can you tell me any of these symptoms?
Well, I know she has anemia, and she's very pale, very white. You know, she has bruising and bleeding. She gets a lot of nosebleeds, bleeds from the gums. She has bone and joint pain. There's, you know, some swelling underneath her, you know, in different parts of her bodies at time, and lack of appetite. And she's just had a lot of weight loss.
You sound very well read on the symptoms of leukemia.
Yes. You know, when I saw that she was struggling with something, I felt like it was my duty as her mother to go and advocate for her. It's very important that I advocate for my child. She's my life.
Well, it should be. Yes. I mean, from any mother's standpoint, you want to get the best care for your child, and this sounds concerning. Do you have anyone else in the family that's a support system for you right now with this?
No, my parents are divorced. My mother is not around anymore, and her father, Ken, we divorced when she was 4 years old, and he's not in the picture. It's just me, but I know that I can take care of everything that she needs.
All right. Priscilla, can I speak with her for a minute? Or
she's so exhausted from all this stuff that I really, and she doesn't really understand the medical terminologies and
understandable.
all of that. So I do all the talking for her.
All right. I was just going to check in and see how she was doing, but if you're answering all the questions and you know what's going on, that seems fair.
Yes.
All right, so let's see what else I've got here in my notes. I apologize for looking at these. Usually I am more on my feet, but today's been kind of a weird day. Let's see. You know a lot about what's going on, and you said that people aren't hearing you. From what I see in the records, you've been to 3 different facilities over the last 10 months trying to get some information or some kind of answer and treatment on Priscilla?
Yes. Yes, because I know that she's got leukemia, and she needs assistance. There's tests that need to be ran to show that. And like right now, there's these little bumps that she's been complaining about underneath her arms that are lymph nodes that we need to get a biopsy done on.
Yeah, a biopsy so you can see if there's anything going on and get the kind of treatment your daughter deserves.
Yes, I want to catch this before it goes so far that I lose my daughter. I don't want to lose my daughter.
Completely understandable, because you did say she's your world, and it would be so hard. And if we miss this, a real negligence on our part for not being able to catch this. Doctor, are you with me? Doctor, let's see, where are you at? Did you come into the room yet?
Yes, I'm right here.
Okay, I am so all over the place today. You had some tests run, correct?
So from the medical perspective, when you brought Priscilla in, we did note that she is very thin, very weak. We did note the abnormal bleeding, high fever, so symptoms that are consistent with the diagnosis of leukemia. But where we're struggling from a medical perspective is that with all the tests we've run, the blood analysis, all the things that we're running, we are not finding any evidence to say that the cause of those diagnoses, the cause of those symptoms are leukemia. And that is why right now we're hesitant to do any more invasive treatments like a biopsy, because from all of our medical scans that you would do when someone has leukemia, we are not seeing any evidence from the medical tests themselves that her symptoms are being caused by leukemia.
Are you sure those tests? Are you sure that those tests? Because you have a percentage of failure on tests.
We can absolutely run those tests again, but these are the most advanced medical tests for a diagnosis of leukemia, and it's very rare that we're going to miss something when those symptoms are present. From 8 months now, at the 3 different hospitals that you have been to, one thing that we're seeing with the medical records that you brought in, and thank you for bringing those in, it does save us time not having to get those and try and make that call to get all those medical records. So from reviewing those records, we are seeing that that's also been noted at the other 2 hospitals that you brought her to in terms of the symptoms that she's presenting. They are serious symptoms and we are taking them seriously.
Absolutely
But
serious.
the medical tests that we are running aren't showing a clear cause of what those symptoms are.
So what you're telling me is that you're telling me you believe she doesn't have leukemia.
We're not saying that.
What I'm telling you, from the medical tests that we've run, we're not seeing evidence to support a diagnosis. So that is why we haven't made a diagnosis, because we have to make our diagnosis based on the medical evidence and do we have enough to support that. We are not saying that that couldn't be a possibility, but as of right now, over the past 10 months and the time that she has been brought in, we don't have enough medical backing to make that diagnosis.
That's part of why I've come in on this, because this has been a long-term case. I'm now working as a case manager to help be a liaison between you and other medical facilities. This is important. We are not saying anything of this being fictitious, made up. Your concern is real and genuine and valid. I just want to make sure that we are looking at this from all angles, as the tests aren't showing anything at present. That does not mean that nothing is there. So with a long-term case management, we can look at other presenting symptoms over time. We can do a lot more things to see how long this has gone on, talk to other people who might have been involved, just get a whole picture and be able to paint that for our clinician team so that your daughter gets the best care possible and that worst case scenario you talked about does not happen. That is the absolute last thing we want to happen here.
So you're done with your testing, and now and you're wanting to continue with observation. So when are you saying that you want to discharge my daughter?
So
We've been thinking about a 24 to 48 hour period. Is that correct, doctor?
yeah, so as of right now, the symptoms that she was presenting with when she came in, like we said, they were serious symptoms. That's why we admitted her. Those have all started to remit. The fever is back down. She's looking like her complexion's coming back. Some of the abnormal bleeding has subsided. And as those symptoms begin to remit, we are going to discharge Priscilla from the hospital. That's just our policy. We can't keep her if there's no medical diagnosis related to those symptoms. That
Now, we can refer her. We can refer her to a childhood a rheumatologist or someone who is a specialist that works with leukemia and start working on that outpatient basis to see how we can track this case. And if anything else pops up, that you can come back in on this emergency basis and the team will be here to treat and test as necessary.
I see.
So we're trying to get that connected and make sure that you have those resources available. Like if you need financial assistance, if you need childcare, if you need anything, my job is to make sure that you have that and that Priscilla, again, gets the best possible care we can give. This is the #1 center in the region for childhood leukemia. We are very serious about what we do. And we're very serious about the concerns of parents who have, like you, done the research, put the time in, and know what they're talking about. We just want to we don't want to put Priscilla under any undue stress because of what we're seeing with the symptoms remitting.
Well, I thank you for your concern. I thank you for your, but as I said to the other hospitals, she does have leukemia. And, yeah, I thank you for the offer for the other doctors. But I believe I'll be signing her release papers and looking for someplace else that will listen to me about the situation with my daughter. Thank you.
Completely understandable. Thank you, and we can get those papers to you in the next 15, 20 minutes, if that's fine with you.
That'd be fine.
All right. Thank you so much. I wish you the best of luck. Priscilla, I hope you get some sort of relief and feel better. And Monique, it's, like I said, it was an unfortunate meeting, but it's been a pleasure to know that you are someone who is so concerned about your daughter and putting in that work and effort. I'm sorry we couldn't do anything for you here. Maybe at the next facility they will be able to.
Thank you.